Good morning, respected members of medical fraternity. I, Suresh Tiwari from INTAS, welcome you to this novel initiative of Mumbai Hematology Group. Today's webinar is on an interesting topic, multiple myeloma, choosing treatment wisely in our country. So we are fortunate to have Dr. M.B. Agarwal sir, who is known to all and is an institution himself. And we are fortunate that he has enriched us by collaborating with multiple stalwarts in hematology across the globe by bringing them on virtual platform. He has been awarded Inspiring Hematologist of India Award and Guru Drona Award recently. Today, we have a renowned hematologist, Dr. Amit Khurana. So, Dr. Amit Khurana sir is a highly skilled and experienced hemato-oncologist with a decade of experience in the field. He has a fellowship in BMT, hematology, clinical hematology, and is an expert in managing hematological oncology patients. He has extensive experience in both autologous and allogeneic stem cell transplant. Sir, over to you for the course of presentations.
Thank you, Mr. Suresh Tiwari, for that kind words. Well, very good morning to all of you, and good afternoon and good evening to all others who are joining from the rest part of the world. Today, our guest speaker for the day is Surgeon Commander Dr. V.A. Arun from INHS Aswini, Mumbai, and he's going to lecture us on multiple myeloma, choosing treatment regimens wisely in our country. This webinar is brought to by Mumbai Hematology Group, supported by INTAS and managed by Perfect Square. I thank Dr. Manoj Kumar and team INTAS, Mr. Yash, Mr. Kalpesh and the team Perfect Square, Executive Committee of Mumbai Hematology Group, our chief guest for the day, Dr. Pavan Kumar Singh from Gurugram, our guest speaker for the day, Surgeon Commander Dr. Arun V.A. from INHS Aswini, Mumbai. All our discussions were themselves very eminent hematologists and hemato-oncologists, and you participants for spending your Sunday morning, afternoon, or evening from whichever part of the world you are logged in. Let me give you a flavor of our next weekend activities. Next Saturday, that is 15th of June 2024, from 7 p.m. Indian Standard Time and 9:30 a.m. US Eastern Time, we have Dr. Stephen Pipe from Ann Arbor, USA, speaking to us on new therapies for hemophilia. And the following date, it is Sunday, 16th of June 2024, from 11:30 a.m. Indian Standard Time and 8 a.m. Belgium time, we have Dr. Cedric Hermans from Belgium, speaking to us on living with a hemophilia-free mind, the new ambition of hemophilia care. Let me introduce our discussions for the day, and we have a galaxy of them here displayed in alphabetical order. To start with, we have Dr. Aditi Shah Kaskar from HCG Hospital, Borivali, Mumbai, Dr. Aishwarya Raj from Shelby Multispecialty Hospital, Ahmedabad, Dr. Amber Garg from DKS Hospital, Raipur, Dr. Ankur Ahuja from FMC, Pune, Dr. Ashutosh Panigrahi from AIIMS, Bhubaneswar, Dr. Dinesh Sheth from Mangalore Institute of Oncology, Mangaluru, Dr. Divya Manohar from Madras Medical College, Chennai, Dr. Girish Kamath from SDM College of Medical Sciences and Hospital, Dharwad, Dr. Gopinathan M. from MGM Healthcare, Chennai, Dr. Govind Patel from Dr. S.N. Medical College, Jodhpur, Surgeon Commander Dr. Gurpreet Kaur from Armed Force Medical College, Pune, Troop Captain Dr. Harshit Khurana from FMC, Pune, Dr. Jaswindhini A.R. from Yashoda Super Specialty Hospitals, Hyderabad, Dr. Kripa Bajaj from Basavatarakam Indo-American Cancer Hospital and Research Institute, Hyderabad, Professor Dr. M. Joseph John from Christian Medical College, Ludhiana, Dr. Madhura Tinaikar Deshpande from Bharati Vidyapit Medical College and Hospital, Pune, Dr. Monica Chenareddy from Vaidehi Hospital Research Center, Bengaluru, Dr. P.K. Sasidharan from Government Medical College, Kozhikode, Dr. Radhika K.K. from Nizam's Institute of Medical Sciences, Hyderabad, Colonel Dr. Rajiv Kumar from RNR Army Hospital, Delhi, Dr. Sadashivudu Gundetti from Nizam's Institute of Medical Sciences, Hyderabad, Dr. Satish Kumar A. from Manipal Hospital, Yashwantpur, Bengaluru, Dr. Tejaswini Gudibande from Mazumdar Show Medical Center, Narayan Health, Bengaluru, Dr. Vishwadip Khushu from AIIMS, Nagpur. Now it's a time to introduce our very special guest and chief guest for the day. We have with us Dr. Pavan Kumar Singh from Gurugram. Dr. Pavan Kumar Singh is Director, Blood and Marrow Transplant at Sanar International Hospital, Gurugram. Dr. Pavan Kumar Singh is a very renowned hemato-oncologist and bone marrow transplant specialist. He completed his DM in hematology from the prestigious All India Institute of Medical Sciences, Delhi, and brings with him an experience of more than 18 years. He has an experience of performing highest number of stem cell transplants in autoimmune diseases, especially multiple sclerosis, and has performed more than 900 BMTs, including matched sibling donor transplants, mud transplants, and haploidentical transplants in both adult and pediatric patients. He has also actively participated in various research work and has authored various articles in both national and international publications. His areas of expertise include experience in performing complicated BMTs like BMT in HIV as well as hepatitis virus infected patients, bloodless BMT in Jehovah's Witness cases, BMT in patients on dialysis, and many more. He has also expertise for BMTs in thalassemia as well as sickle cell disease patients. He is a member of Indian Society of Hematology and Blood Transfusion as well as European Hematology Associations. It's my privilege to welcome Dr. Pawan Kumar Singh to inaugurate our webinar and give some words of wisdom. Over to you, Dr. Pawan Kumar Singh.
Sir, I think he hasn't joined.
Should we wait for 5 minutes, 2 minutes?
Yeah, we can wait for a couple of minutes, but
Okay, should we move forward?
Yes, we can move.
Mr. Kalpesh? Yeah, should we move forward, Mr. Kalpesh?
yes, we can move.
Thank you. So, unfortunately, our chief guest has not joined yet, but we'll move forward. It's now time to introduce our guest speaker for the day. We have with us Surgeon Commander Dr. Arun V.A. from INHS Aswini, Mumbai. Surgeon Commander Dr. Arun V. is Associate Professor Medicine and Clinical Hematologist at INHS Aswini, Konaba, Mumbai. His qualifications include MBBS, MD in General Medicine, and DM Clinical Hematology, with very special achievements by representing Indian U16 cricket team from 2001 to 2002 and Kerala Ranji Trophy team in 2003. He has about 44 publications in both national and international journals. To name his awards and felicitation, he received President's Gold Medal Best MBBS Cadet AFMC 2007. He was MUHS topper in first, second, and third MBBS, first in grading exam in MD Medicine, as well as Associate Fellow at NAMS 2022. He has got Best Research Paper in Hematocon 2018, SITSCon 2017, and IBM FS 2022. He was also the winner of National Hematology Quiz, Clinical Infectious Disease Society Quiz, and Epicon 2016. And today he's with us and he's going to lecture us on multiple myeloma, choosing treatment regimens wisely in our country. Well, thank you so much. Over to you, Dr. Arun B.A.
Can you see my slides? Am I audible now?
Again, the same problem, Dr. Arun. Dr. Kalpesh, can you please share his screen?
Sir,
Your end. Yeah.
instead of the window, share the entire screen and then put it on full screen.
Yeah, is this fine?
Yes, that works, sir. Please go ahead.
Okay. Yeah. Thank you, MSG and Dr. Agarwal in particular for giving me an opportunity to talk to an august audience here on the topic of multiple myeloma. This is one disease which I'm been passionate about since I have joined hematology. And I thought I would choose this topic and discuss about how to manage myeloma and how do we choose regimens wisely in our country with all our resource constraints and logistic constraints. So it's a tall ask in the sense I have to cover the length and breadth of the topic. So I would be missing out on some things which I think may not be relevant for our country as well. So I would discuss the topic in the following scheme. I'll go with introduction, discuss mainly about newly diagnosed myeloma, touch upon the relapse refractory setting, and I would conclude with the journey ahead. My disclosures are nil. So what do we know about myeloma in 2024? We do know that it's the second commonest hematological malignancies, close to 2 lakh cases a year. With adequate treatment now, I would say that some of the myelomas do survive 10 years, even in our country. We have at least 10 class of agents available, at least 7 or 8 of them are generics now. We must know that it's a deeper and durable responses which would translate into PFS and OS long term. Whatever we throw at myeloma, finally, we must understand that it is inevitably a relapsing disease. Drug resistance is a reality. So it's all about how do we choose our drug regimens and tailor it to the patient profile. So these are the most recent GloboCan estimates, I would say, in collaboration with the WHO. Important point to know is we have close to 2 lakh cases every year. The mortality is close to 1.2 lakh. And the figure in the green, actually, if you see in terms, either in terms of incident mortality prevalence, this is what the contribution from Asia is. We don't have nation-specific representative data, though we have image coming up from the national platform. We don't have, I would say, realistic data of incidences and mortality as on date. So what has been the standard of care and what should be the standard of care for newly diagnosed myeloma? If you see the world over, I would say, or everyone would say, or the best expert in myeloma would say, is to participate in a clinical trial. That's how patients of myeloma should be managed. But I don't think so that's applicable to us. Even in the West, not many can afford to be in clinical trials. So there are institutional protocols and reimbursement specific standard of care, which follows guidelines, whether they are ESMO or NICE or NCCN. But strangely, in our country, you would see this is the reality. It's the common man who suffers. And myeloma management, I would say, is more economics-based medicine and sometimes eminence-based medicine. We have experts and self-proclaimed experts who believe it's my way or the highway. And that's how myeloma is managed or mismanaged in at least some of our settings. Some of the institutes, Apex institutes, have gone a way ahead, have their protocols, and even some of their retrospective data published. We don't have prospective data published from any of the institutes still. Clinical trials is a far cry for most of us. No prospective phase 3 trials where patients are enrolled, even in the best of the institutes as on date. So before I move any further, we must have a guesstimate is what I would say of myeloma in our country. Some literature puts it as 20,000 odd cases a year, but I would say that's underreporting and underrepresentation. If you see the incidences, the number of cases would be close to 30, 40,000. The median age at diagnosis, people had made controversy about it that we have younger age of myeloma, but it's not correct. If you see the data, it is almost as good as Western data. The almost 2/3 of patients would be standard risk, but 50% of them would be transplant eligible maybe. But the number of transplants for myeloma we do, even if you go by the latest ISBMT data, where more than 110 centers have logged in it, we do around 500 to 600 transplants in myeloma. The attrition rates for a patient are fairly high, 50%, I would say, is a very optimistic figure. So what has the government done? We have an essential drug list, which the government has come about and has revised it recently. And if you see the essential drug list, which is based on these attributes of an essential drug and the priority health needs of the population, the essential drug list of WHO has 502 drugs. That of our nation is 384. Lenalidomide, bortezomib, cyclophosphamide prominently features in that. Lenalidomide was recently added. I set the ball rolling discussing a simple case of a 55-year-old symptomatic myeloma patient who comes with bone pain. The frailty is an important part of assessment. That's not the topic of discussion, so I would skip that. But this is a fit patient who has, you would see clonal plasma cells, IgG kappa, standard risk cytogenetics, and he qualifies for treatment. If you ask the best in the field, what would be the strategy for this patient, newly diagnosed myeloma, transplant eligible, standard risk? You see that I've given you 7 options, and the 7th option is other options. So there are so many options. Why? Why do we have so many options? So if you ask the best in the field a year ago, they would come out with these options. So what does it tell us? It tells us that even the best in the field, supposedly, doesn't have a consensus. So that's reflected if you see even in the recently held IMF consensus document. If you see, they do classify myeloma as standard risk and transplant eligible and so on and so forth. But we don't have a regimen because it is actually one size doesn't fit all. That's the beauty of myeloma, and that's also the problem with myeloma management. This is what NCCN does and brings out almost every year. So there are preferred regimens in the NCCN for transplant candidates. And you will see strangely the daratumumab, the quadruplets come in the other recommended regimens. And why are these other recommended? Because even they have considered logistics and finances like our nation. That's why Dara may not be in the reach of so many patients. If you go to the ESMO guidelines, which is as current as 2021, they don't differ. It's usually a triplet now. That's what we do for most of our patients, whether they are transplant eligible or not, unless they are frail and they are going for a doublet. This is what the institution where I come from. I was part of this protocol development as well. And I'll discuss it in a bit detail as I go forward. So this is what we have from all of the phase 3 trials if you combine. The left half shows the workhorse for us, that is the BRD or the RVD. And you will see the PFS is close to 40 months if they are not on a transplant regimen. And if you consolidate with the transplant, you get a PFS of 67 months. We'll have to tease out the subset groups or subgroups to make meaningful inferences of these. And on the right half, you will see when you put in quadruplets, the PFSs are definitely better. But do they all, is that what actually matters when you take a call from the national point of view? So this is the workhorse for most of us. And the SWAP trial brings out beautifully the data with VRD, whether the patient is going up for a transplant or not. If you have a mixed PFS bag here, you will see the PFS is 48. What I want to tell you is, again, if it is compared, the VRD was compared against a doublet here. So you will see definitely it performs better than a doublet. There's a lot of separation in the PFS curves. But what is important to know if you do a subset analysis is people above 65 and beyond don't gain too much from the VRD regimen. So that's what we should know. And these are Western data as well. So I would just say that although this is actually what serves most of our population, and this is what most of the population can afford, you would see that if you put VRD ahead, we need to consolidate it with the transplant, and that's when you can actually improve upon the PFS benefits. And I would tell you that it's about PFS, long-term PFSs, which will matter because most of our patients cannot go on to a second or third line regimen, basically because of cost constraints. We move on to a case 2. It's about a 65-year-old frail lady, and it's again evaluated for symptomatic myeloma. And you can see it's IgG kappa, cytogenetics is normal, and this becomes a transplant ineligible patient. And again, when you have transplant ineligible, again, the options are so many, plenty. Now, how do we go about choosing a regimen in a transplant ineligible patient? So if you see these are phase 3, phase 2 trial data, we again can go back to the VRD kind of regimen or a VRD like kind of a regimen, which is less intense. And you can get meaningful PFS close to 42 months in this subset of transplant ineligible. Or you can embrace on the Maya trial, and you would see that's what you actually would see the benefit of putting somebody on continuous therapy with DRD, that is Dara Lendex. But that puts the patient at, in fact, I would say a lot of financial and sometimes a clinical toxicity of the regime. That's where we must understand how to choose wisely. So this is what the Maya trial latest update about Maya trial. You see the curves keep separating, and this brings about a meaningful PFS and in fact a meaningful OS benefit as well. But not everyone is the same. That's what I said. One size doesn't fit all. So we have subsets who are elderly, frail. There is high-risk myeloma, both cytogenetically and otherwise. There are myeloma patients who come with renal dysfunction, and then there is ultra high risk and plasma cell leukemia. If you see managing the data about managing myeloma newly diagnosed in the elderly, and I put in a cutoff figure of 65, and we must understand that a Western 65-year-old is close to our 70, 75-year-old in terms of fitness. What I want you to look down is, again, the PFS benefits, which is given by upfront Dara in some of these, and our workhorse, which is VRD. Suffice to say that most of our patients still would benefit from a triplet, but beware you, if you have a doublet like a Lendex, the PFSs are not too bad. It's 26 months to 34 months. The overall survival is fairly good, even in such subsets. So this is the subset actually we are going to face in more than 50% of our newly diagnosed cases. So doublet is not to be written off in this subset. If they are frail and not fit for a triplet VRD is still the way to go. VMP is a decent option for some who are not, most of these patients who are not transplant eligible, and VRD light would be another option. This is actually burning your fingers when you go intense. This is a trial actually, and beautifully even, despite being a negative trial and the therapy being prematurely discontinued because of toxicity, they went on to publish this data that if you put too much of drugs, it's a quadruplet regimen of ixazomib, Dara and Dex, and you will see that it actually doesn't work in the elderly and frail. Myeloma, I would say about 10 to 20% of patients come with upfront cast nephropathy. The existing standard of care has been a VCD or a VTD based regimen with high dose DEXA. Some of us use a plasma exchange or a high cutoff dialysis to wash off the light chains and improve the renal outcomes. That's one way of going about it. But there is some data that Dara does well in that subset as well. And for those patients where you could discuss it financially and logistic, adding Dara to this backbone of VCD or VTD would help. There is even data to say that Len adjusted as per the EGFR is useful. When it comes to high-risk cytogenetics groups, which almost constitute 1/4 to 1/3 of myelomas upfront, it's the cytogenetic group. If you see the data from these phase 3 trials where a quadruplet was used, and in fact an anti-CD38 antibody was used, you did get meaningful PFSs, and there is some meta-analysis which says that anti-CD38 or a quadruplet may work. But I would still say for high-risk myeloma, nobody knows what's the correct regimen or sequence of regimen. In fact, you could use all possible therapy combinations, and we are even discussing about bringing in CAR-T or bispecifics upfront in this subset. So I would say the treatment of high-risk myeloma is still a matter of debate. There is some trial going on. Could you intensify therapy with quadruplet consolidation? Leave aside induction with the quadruplet and an early transplant in this. That may be the way forward, maybe for the people who are fit. And there is data to say that they do well. With that, if you could sum up, and if I could sum up the optimal induction regimens in this country where generics are available for all these, whether it is bortezomib, cyclophosphamide, carfilzomib, even pomalidomide for that matter, and thalidomide. For a transplant eligible, I would say fit patient, triplet would be the way to go about. VRD, VCD, VTD still says. For some of the high risks, you may consider carfilzomib. For the frail and the elderly, I would say a doublet to start with, and if they improve their PFS, yes, triplet or a VRD light would be ideal. In somebody who's transplant ineligible, the same therapy will hold. But I must make it a point that the way the world is moving ahead, and because the patent for daratumumab is expiring somewhere in 2025, and maybe when we have generics coming up, and for somebody where the finances are not a problem, and it is logistically viable for some of the patients who are on DARA for an stem cell cryopreservation, DARA needs to be discussed in such a patient. Special groups, I discussed how to go about managing them. So with the generics available, I think we are not far off from what we can do with the triplet. The way ahead, in newly diagnosed myeloma for a world across is something which is MRD based. We can't move away from MRD anymore. This is a recent publication in Blood, which again brings forth the fact that if you do have a sustained MRD, the odds of having a good PFS is close to 4.02 and 7.67. So we can't get away from MRD in times to come. There is enough data, at least from the Western literature, where it says that sustained negative MRDs translates into meaningful PFSs and even overall survival. But do I use MRD in clinical practice today? I would say no. In most of my cases, there is some role where you could use MRD, maybe pre-transplant and post-transplant, to prognosticate a patient, to risk adaptive therapy in somebody who is not improving, to take somebody off maintenance therapy, especially if they're doing pretty well, somebody who sustained MRD negative standard risk. There is now data that beyond 5 years, LEN maintenance could be stopped and pause for a moment. And there are people who have even gone on to see whether PET adapted therapy helps. So this is a recent publication in leukemia from the European group, where they have gone on to see whether somebody who is PET positive, intensification of therapy post-transplant, does it help? And they've gone on to see that if you do a KRD consolidation, at least 1/3 of these patients could be translated into PET negativity. But whether that translates into meaningful survival, only time will prove. When you put in or push in quadruplets and you do MRD guided therapy, this is something which might be happening in foreseeable in the future. With so much of transplant burden, especially in our country as well, if you could push somebody to sustain MRD negativity, this is the real world data with DARA KRD without transplant. There is data to show that almost 70% would reach a sustained MRD negativity, wherein you might avoid a transplant. Now we'll have to watch out for the phase 3 study, which is the MIDA study, which would delve on the topic. The master trial was another master stroke, I would say, from the West, where they would use a quadruplet upfront and then a consolidation with a quadruplet again, and intensify it based on the MRD. And based on sustained MRD negativity, they will take the patients off therapy. It's a proof of concept study, and you would see that the 123 patients enrolled, 20% above 70 years, almost 50% were high risk and 20% were ultra high risk. They could achieve what they could achieve, that is 80% could achieve MRD negativity when you go on such a protocol. Serious adverse events were reported in the form of thromboembolism and pneumonia, which we want to avoid. And you would see 70% were MRD sure. That means people who were MRD negative sustained for 12 months, only 9% went on to progress when they followed up these patients for almost 3 years. So this is not, this is actually, I would say, a promising data, but it's too much of intense therapy. And even when you put so much of intense therapy to some of these patients, the lowest curve is somebody who has 2 high-risk cytogenetic abnormalities. This is the ultra high-risk myeloma. Even this kind of a regimen doesn't help that subgroup. Coming back to what we can do for our patients post-induction, we must transplant as many as we can. There is a lot of data and debate on whether early transplant or delayed transplant is the way to go. The IFM 201/2009 did say that the PFS is what differs. And if you transplant early, you could reduce it by 30%. Overall survival, 8-year follow-up data, you would see that overall survival curves don't differ, whether you do an early or a delayed transplant. This was the determination trial, which again looked up the similar conundrum, and that was again based on an RBD platform applicable to us. It did say the same thing. that the PFSs are better, 46 months versus 67 if you transplant, but if you do transplant later also, the overall survival doesn't differ. A word of caution for all of us and for the younger lot and people like us who are actually starting to skim the path of myeloma management. Early transplant is the way to go. This is what I believe, because these PFS benefits, which is being alluded to in this trial, at least in our country, would translate to delayed need for second line agents. You know, when you do an early transplant, the bone marrow reserves are optimal, and that facilitates stem cell mobilization as well. And you all already know that most of our patients have a median age of 65 at presentation. How many of them are going to be transplant eligible if you delay the transplant maybe for 2 or 3 years subsequently? That I think is a singular point where I would say when the best therapy has to be upfront and when the patient is fit to do that. This is a beautiful study which I think I came across in the recently concluded ISBNT. This is a beautiful, I would say, poster from one of the centers in Mumbai where actually they proved that you could move away from or I would say tier 1 cities and set up small transplant centers and dedicated transplant centers for myeloma. And they did show that is doable. If you have SOPs in place, trained nursing team in place, you could do more transplants in myeloma and consolidate a lot many. I think this is the way to go for myeloma transplant in our country. A very important part of myeloma management would be the maintenance strategy. Most of us start maintenance, at least in standard risk patients who have VGPR in about 3 months post-transplant. And most of us do a LEN kind of maintenance, that is single maintenance, single drug maintenance. There is data for double maintenance with bortezomib and LEN in high-risk myeloma. What I want to tell you is there is now data that the LEN maintenance need not be unlimited. At least in the standard risk patients, if you can bring in MRD data, if the patient has been on LEN maintenance for 3 years or maybe 5 years, you can go off LEN maintenance in that population. And why do we need to go off LEN maintenance is definitely the risk of myelosuppression, bone marrow reserves, and definitely the risk of secondary primary malignancies, which is attributable to LEN. There is meta-analysis with lenalidomide maintenance now. So the jury is absolutely clear that LEN maintenance is the way to go, and you will see people who are on LEN maintenance, the blue curves separate out from those without on a placebo. So I would say it is unethical to put somebody not to put somebody on that kind of maintenance. This is a study which must be the way to go for most of us. This is a Canadian study, and you would say we go with the West saying they are mostly into quadruplets and hi-fi stuff and MRD. This is actually data of close to 3,800 patients who just received Cy/Body, that is VCD, and LEN maintenance indefinite. But you would see what they did was most of them were transplanted early on. And you would see the meaningful PFSs and OSs are more than 10 years. That's what I think what we should allude, not go for fanciful stuff, quadruplets, anti-CD38, maybe, till the time the logistics and finances are ready, and do what we can do best. A triplet, maybe doublet, in frail, early transplant, consolidation, indefinite maintenance. That's the way to go about. This is something which I discuss with every myeloma presentation. This is how the access for myeloma therapy is in real world. And this is data mostly from the West and the European nations. You would see that if you see around 95% patients enrolled up in the first line, and you see as you go up, the attrition rates are fairly high, about 20-30% in the third or fourth line. And the reason why people opt out of therapy is either because the disease progresses so fast as we move ahead in therapy, or there is too much of toxicity, again, both clinical and financial. Before I wind up the discussion on the newly diagnosed myeloma, this is one of my thesis studies, which I did as a part of my DM program. And what is scary is the data on early mortality in myeloma. The West has dealt with it. Now the mortality is to the tune of less than 10%. This is the death in myeloma in the first 3 to 6 months, and maybe even for 60 days. I would say 60% is attributable to infection, 30% is attributable to renal impairment in such settings. And what we did found out was it was infections predominantly, and that was a COVID pandemic that time, so that played into it. But I would say this is something which we have to improve upon by improving the supportive care in myeloma. So we immunize all our myeloma patients upfront with pneumococcal vaccines and influenza vaccine yearly. We put patients on acyclovir prophylaxis who are on the bortezomib, and definitely those who are on anti-CD38. There was a hue and cry from the West about levofloxacin prophylaxis and the THEME trial data, and some of the Western centers do follow levofloxacin prophylaxis in upfront in the first 3 months. That's not a valid proposition for us. You know why? Fluconazole and Ceptran prophylaxis are used in somebody. Usually, we do it when somebody is having mucositis upfront, somebody who's a diabetic and is on having plasma cell leukemia, or you're doing high dose DEXA. That is the place where you would use fluconazole and Ceptran. Otherwise, it's not part of routine. Among born disease modulating agents, pamidronate or zoledronate works as good as denosumab. There is no need to go for denosumab. Thromboprophylaxis is risk adapted. Most of them do well on ecosprin. But somebody who has an added risk factor, there are myeloma specific thromboprophylaxis risk score as well. You would have to add a heparin or warfarin or a dual antiplatelet in such a scenario. So if I have to sum up newly diagnosed myeloma management, you must use best agents upfront. Attrition is a reality. Sustained deep remissions would translate into meaningful PFSs. Leverage what is the best available immunotherapy, whether it is transplant or DARA, or maybe CAR-T or immunotherapy or bispecifics in the later line. Autologous transplant has a definite role in today's world of myeloma management. Maybe the way forward is response adaptive therapy. At every point of time, discuss quality of life and goals of care. Minimize therapy-related and financial toxicity. Before I wind up, just a few 5 minutes on the relapse setting. When we take patients up for therapy in relapse myeloma, lot many factors are considered: disease biology, patient-related factors, and treatment-related factors, whether it is a biochemical or a clinical relapse. There is even data to say that some of the biochemical relapses, if you follow the dynamics, needs treatment. This is how it shapes up. Most of our patients, now are on upfront bortezomib and len. For those who have early relapses, they are both borti and len resistant. But somebody who has had a meaningful PFS post-induction, they are usually len resistant. Even I would say somebody on len low dose 10 should be considered len resistant, and that's how do you choose your therapy upfront. And definitely, if somebody who has not received an autologous transplant upfront, depending upon whether the patient was on maintenance or no maintenance, you could use it as a salvage. So for the blessed few who are not on lenalidomide, I think most of our patients do embrace it and use it as a part of our maintenance. You will have to bring in anti-CD38 here, or you'll have to bring in pomalidomide or carfilzomib. And these people do have meaningful PFSs. But somebody who's len refractory, as most of our patients are, if you don't have access to DARA, which gives you, I would say now there is even survival benefits as well, that you would get a PFS of 2 years and above. Most of our patients would only have access in such a scenario to either carfilzomib or pomalidomide. And even then, you would get a PFS of 1 year or more in most of our patients. There is data now from phase 3 studies. But somebody who relapses in the second line or more, we don't have much. Even you offer the best, the PFSs you would see is less than a year. That's when I would say the immunotherapy is a way to go. And you would see the approvals have come one after the another. The CAR-T cell in the form of ID cell and Silta cell, and then the bispecifics in the form of teclistamab, talquetamab, and elranatamab. At least some of these bispecifics are going to be available by year end for I would say, the person who could afford it financially. A brief outline about the bispecifics, that the teclistamab, erlinitamab, and the talquetamab. What is important to know is they would give you meaningful responses. Overall response rates in such heavily pretreated positions will be to the tune of 2/3. But the duration of responses again is short-lived, and we will have to have some strategy to consolidate these responses. The CAR T data is out, and I've just flashed the BCMA-based CAR T data. Again, you would see the overall responses are fairly good with good stringent CRs as well. At least with cilta-cel, there is a lot of meaningful PFSs to the tune of 2 years and above, and cilta-cel has now moved into earlier lines of refractoriness. But when you compare CAR Ts and bispecifics, both of them are T-cell health dependent targeted immunotherapies. Bispecifics are available off the shelf, so you could use it upfront. CAR T needs to be personalized and people have to undergo a lymphodepletion. The toxicities vary a bit, with a bit more neurotoxicity when you use CAR T and a bit more hematological toxicity with bispecifics. Hospitalization services are an absolute essential with CAR T, although it's a single infusion. With somebody who has a good organ reserve fitness, CAR T would be the way to go. With somebody who's unfit and has no much time to offer, bispecifics would be. The costs are prohibitive. And that's when I would end by putting this wish list ahead in front of all of you for myeloma care in India. I think the way forward is collaboration. Unless we talk to each other, share data on a common platform, we can't have advocacy. We as physicians in myeloma or maybe hematology or general physicians cannot apprise the government of the magnitude of the problem and won't have any consensus amongst us. What should be the way to manage a patient upfront and in the relapse setting, and how to sequence therapy with the available resources. This is the data from the American Cancer Society. Beautifully see. We have to follow Westerners in some account, I would say. Every single case is accounted for. The deaths are also accounted for. We need to have consensus guidelines and compliance to these, and not eminence-based medicines. Our essential drug list has to expand. And how do we do that? We have to bring in pharma, we have to bring in the government, and we have to advocate. The way forward is for biosimilar and generics, even for the monoclonals. And yesterday we had the talk on CAR T, and I would say that's the way to go. Dr. Narula was alluding to in-house low-cost CARs to come up maybe in 5 years from now. Access to transplant has to improve. I think that's what I would say the poor man's immunotherapy is all about. We have access to clinical trials, rather very limited. And I think we have to advocate and we have to come forward and collaborate with both the pharma and the industries to have clinical trials, patients enrolled on that to move any further in myeloma. Supportive care has to improve, the access has to improve. That's when we would bring down the early mortality in myeloma and improve the quality of life. We must have goals of therapy defined and access to palliation and myeloma support groups for most of our patients who need them. The world is going behind or making a hue and cry about MRD, and unless we have access and standardization of MRD in our settings, I would say it's a far cry for most of our patients. With that, I end, and I would come back to this favorite slide of mine. Most of us should not lose sight of this when we manage myeloma. Thank you all for a patient hearing. Thank you, Imagine, for this opportunity. And I bring you greetings from the institute where I work in. Thank you, one and all. And I'm happy to take any questions, if any. Thank you.
Thank you, Dr. Arun, for that wonderful talk. That was fantastic. It really was shown light on how should we manage patients in Indian scenario. That's really beautiful. Thank you so much for being with us as a guest speaker. Your talk was fantastic and super. I now request all our discussants to please put the raise hand sign so that we can start our question answer session with Dr. Arun. Yeah, Dr. Shada Seudhi Gundeti, your question, please.
Wonderful talk, I think, as usual. Only one question. I think whenever we want to start something quadruple DARA-based therapy for induction, so do you again give the maintenance therapy DARA? Are you able to hear me?
Yes, sir. Yes, thank you, sir. Thank you for the question, and
Yeah, it's a
thank you,
wonderful
sir,
talk.
for.
It's really we enjoyed. Yeah.
Thank you, sir. Thank you, sir. We look up to you, the kind of expert work which you have done on in the field. So we are all proud of it, sir. So this is my personal take on upfront quadruplets. So if you go by trial data, they are part of the regimen. When you have patients who are thrown to us, where finances are limited and the risk of infection is definitely unlimited, possibly. I would definitely, if I have used DARA upfront in induction, I would definitely try to avoid it in my consolidation. And definitely when I do DARA maintenance, I would not exceed more than a year. So most of the patients, when I do DARA, I would rather give it in the induction, consolidate with an early transplant, put them on maybe a doublet maintenance. I would skip DARA in the consolidation and maybe in the maintenance arm in most of my patients.
I do agree, completely agree with you, because very difficult to maintain the continuous DARA in Indian context is again because Western data literature, everything, whatever they say, but ultimately Indian context is we'll try to give them some good induction therapy, get the MRD negative. I think based on that, I think we can choose the therapy and tailor therapy accordingly. Thank you, wonderful talk. Thank you. All the best.
Thank you, sir. Dr. Satish Kumar, your question, please.
Yeah, thanks, Amit. Thank you, Dr. Arun, for that wonderful talk. I had a couple of questions. For high-risk myeloma, what is your suggestion practically? What is the best treatment? And what maintenance do you suggest in high-risk myeloma? Doublet or only lenalidomide?
Thank you for the question. So again, high-risk myeloma, it's an entire debate. There is no consensus. So if you ask me what do I do for my patient, that's what I would say. And that's based on a combination of both science and philosophy. So again, finances unlimited, logistics available, cryopreservation possible. I do a quadruplet in my patients. I take them up for an early transplant. I collect stem cells maybe after 4 cycles and do an early transplant. I consolidate in such scenarios based on the pre-transplant MRD, do 2 consolidations, and post-consolidation, I put them on a doublet maintenance. If they can go ahead with DARA, it is a DARA-len maintenance. I don't do len maintenance alone in high-risk subsets. I either do a BOTI-len or a DARA-len maintenance. Len maintenance is continued beyond 2 years. DARA, if they can afford, yes, for a year, and beyond that, it's plain len maintenance or a BOTI-len maintenance, indefinite till progression.
Okay, doctor. And so indefinite in high risk. Standard risk, as you rightly said, people who are on len maintenance, when they relapse, even I have seen whatever you throw, carfilzomib or even DARA or pomalidomide, they usually, the progression-free survival is 1 to 1.5 years, as you rightly said. So should we limit, I mean, there's some data that in standard risk, of course, I completely agree about MRD, but should we limit the len maintenance to 2 years in standard risk?
Yeah, that's another, these are all, I would say, way forward philosophies in myeloma. So if you read through the post-hoc analysis of the myeloma 11 trial, this is actually discussed in detail. So what they did point out is in somebody who is standard risk, len maintenance, the odds of benefit are maximum in the first 5 years, and that too in the first 3 years. So somebody who is standard risk, if you do 3 or 5 years of len maintenance, you can discuss going off len maintenance. If the patient is ready to take the risk, take him off len maintenance. If you can put in MRD and have that data as well, and if you could sustain MRD negativity in that subset, that is I would say, the ideal patient who is standard risk, sustain MRD negative, beyond 3 years, beyond 5 years, you can stop len and wait and watch. There is data now to show that that's the way to go forward. Yes, I completely agree.
Yeah. Thank you so much, Dr. Arun. Thank you.
Thank you, Dr. Satish Kumar. Dr. Tejaswini Gudivande, your question, please.
That was a very informative talk. Yeah, I have 2 questions. One is, I have heard that in the armed forces, every soldier is given due treatment, so they can opt for any is it true that they can ask for costlier treatment? Like, is there a limit, or is it true that each soldier is given the best possible treatment for a disease? And one more through the talk, what I wanted to ask was refractory disease, when they're getting multiple triple therapy or quadruple therapy, how do you make out that the patient is refractory to one particular treatment, one particular drug?
Thank you. Thank you for the two questions. So first question is very close to our heart. So armed forces, I would say, yes, we give what best is possible on that particular day. But having said that, we actually plan it way ahead. I would say we move. I would say I've always held this paradigm. If you keep West and their radical ideas as you keep it at zero or baseline, in some of the apex institutes like PGI, Vellore, and maybe others of them are maybe 3 to 5 years behind them in terms of what they do. The government medical colleges, I would say, are maybe 5 years behind them in terms of radical and maybe say state-of-the-art therapy or whatever you can say. Armed forces is somewhere in between. So what we did was with daratumumab, we engaged into something called as a rate contract with the industry. And when you have rate contract with the industry, that's when we have access to these drugs unlimited. But having said that, we cannot put everyone on that regimen. So we do risk stratify. We have tumor board meets where we discuss at length and dissect out who should be on regimen, especially if it is financially not viable. So we just don't do cut copy paste Perseus trial or Griffin or Maya. We don't do DRD indefinite in any of our soldiers. We still go with the workhorses. That is a triplet standard BRD, but we do transplants. We do indefinite maintenance in our patients. So that's something we do better. And follow-up, robust follow-up is what we do. So, and definitely supportive care is good. So all of it put together, the results are definitely a shade better than what most of the centers do in the country. Regarding the second question, that was about how do you, when you have a mix of drugs on which a patient progresses, how do you make out? So if you go by the definition, if somebody is on a drug beyond 60 days and he progresses on that, if it is single agent, it's very easy to make out it is that with the patient is progressing. So that's how Len refractoriness and all is defined. So if somebody is on maximal tolerated doses of a drug and he progresses on that beyond even after 60 days of exposure, you will call it as refractoriness. But having said that, some of our patients are on upfront VRD, and if they progress early post-transplant and you don't have a meaningful PFS of maybe what is expected, like if somebody is on a triplet like VRD and progresses early transplant, although he may be on Len maintenance, I will consider that patient as both BOTE and Len maintenance, because with BOTE and Len, with VRD transplant and a Len maintenance, you are expecting a PFS close to maybe 5 years or 3 years. So if somebody progresses during that period, that's a functionally high-risk myeloma. So I would consider them resistant to both BOTE and Len. Otherwise, I will stick to the definition of 60 days.
Any other question? Right. Dr. Ashutosh, your question, please.
Good morning. It was a nice talk, Dr. Arun, and thank you for elaborating on myeloma. I have two questions. One is, what is your approach for patients with plasmacytoma, either a single or multifocal or multiple myeloma associated with a plasmacytoma? How you usually approach to them? And second question is associated amyloidosis. Suppose multiple myeloma and you are finding a amyloid deposit. What is your experience and how you approach them?
Thank you for both the questions. So regarding plasmacytoma, there is some consensus, like if you diagnose somebody as plasmacytoma, before you label him as solitary plasmacytoma, we must image two compartments, right? So we do a whole body PET or an MRI and say there is no plasmacytoma or extramedullary disease elsewhere. Be sure about that. and definitely do a marrow. And we be very clear that it's a solitary plasmacytoma and nothing else. So when you have solitary plasmacytoma with minimal marrow plasmacytosis, that's a patient who can just be managed with surgical or a radiotherapy intervention. That's good enough. But somebody who has excess of clonal plasma cells in the marrow, maybe not myeloma defining events, he is likely to definitely progress into full-blown myeloma. So that patient needs systemic myeloma therapy as well, in addition to managing the local plasmacytoma based on what is the bulk of the disease and what is the patient's symptomatology. So that's how I would manage plasmacytoma in the context of myeloma. About 10% of myeloma patients may have amyloid as well. We do look for amyloid deposits in all our patients, in marrow especially. But when you suspect amyloid and it is associated with a myeloma, sometimes it's the amyloid, I would say you decide the therapy based on what is actually killing the patients faster. So somebody where amyloid is progressing faster in terms of target organ damage, like maybe the renal involvement or cardiac impairment, our therapy is more amyloid directed rather than myeloma directed. That's how we shape it up. With the Andromeda trial, we try to incorporate DARA-VCD as the arm, as a standard of care now in at least some of our patients who can afford it, because it helps both sides. You would say there is now data with DARA-VCD for both myeloma as well as amyloid upfront. So my therapy will be more amyloid specific in somebody who has predominantly amyloidogenic presenting features in the form of cardiac or renal involvement. And definitely if it is just incidentally detected amyloid with no target organ involvement, it will be definitely myeloma directed. And the maintenance in such a scenario, like in amyloid, we don't do any maintenance, right? We just do some kind of induction and take up for an early transplant, and there is no data about maintenance in amyloid. But somebody who has amyloid and myeloma together, maintenance and consolidation will definitely form part of the therapy.
Sir, you mentioned that your target will be myeloma directed and amyloid directed. So can you just enlighten what does it mean? So how we can practice?
So when I say amyloid directed, in amyloid, the inductions are very brief. The kind of chemotherapy which you give, some patients actually don't require chemotherapy. You can directly take up a patient for transplant as well with high dose melphalan. So, but if the myeloma disease burden is such, you can't take up the patient directly for a transplant, right? So in that scenario, you will have to give maybe 2 to 4 cycles of induction. That's what I said. So DARA-VCD works both ways in such a scenario. So it should help both ways. So, but if it is other way around, if it is full-blown amyloid and just myeloma with no myeloma defining events, and myeloma burden is not too much, we can take up the patient earlier for a transplant after maybe 2 cycles. And definitely post-transplant strategy will differ both in amyloid and myeloma. That is what I say.
Okay, thank you, sir. And regarding your upfront treatment for plasmacytoma, do you prefer any specific regimen or VRDs for all plasmacytomas also? Isolated plasmacytoma, I'm telling multifocal plasmacytomas.
So multifocal plasmacytomas, that is a very rare subset. There is, I would say, not of robust evidence to make meaningful statements. My thought process and my understanding is when you have extramedullary disease, there is some selective advantage for these cells to set up a sanctuary outside. So I would say that, so you don't treat them like conventional myeloma. They are high-risk myeloma rather, and you have to bring in alkylators upfront in such a scenario. So your regimen will definitely have an alkylator, and the alkylator, depending upon, I would say in a transplant eligible patient, you would avoid MEL. You would still use cyclophosphamide in such a scenario. So that's how I would, and definitely would avoid the so I would say if somebody is not transplant eligible, you would have regimens like melphalan, bendamustine, VAD, all of them coming up in such a scenario, because it's just PFS and palliation with no transplant regime, right? In somebody who's transplant eligible, I would still go ahead with VRD kind of a regimen, or if affording DARA, yes.
Thank you, sir. Thank you.
Thank you, Dr. Ashutosh. Dr. Dinesh, you had a question? Dr. Dinesh?
Yeah, hello.
Yeah, please go ahead.
Yeah, thank you, sir, for the excellent talk. My question is regarding the multiple myeloma with renal failure. Whether is it possible to predict, is there any model which can predict which patients can recover completely from the renal failure when they are on dialysis?
I would say there are various renal recovery predicting algorithms which are institution based. And I would say our own data, one of my senior BM residents took up this project of studying myeloma cast nephropathy. And in the multivariate analysis, what did they found out was that I would say the SFLC, the dynamics of how the differentials in free light chains fall post for 2 months of therapy. So you can predict renal recovery when you put somebody on intense myeloma therapy and maybe flex or high cutoff dialysis. You follow the trajectory of free light chain ratios and the differentials. That can give you meaningful insights into how many patients will become dialysis dependent or maybe not dialysis dependent at the end of maybe 3 to 6 months. There are various institutions which follow other set protocols, but my exposure, my understanding, and what we did in PGI was following the dynamics of light chains, the differentials, and the log reduction in the light chains. Nothing beyond that.
Yeah, thank you.
Thank you, Dr. Dinesh. Dr. Aishwarya, your question.
So thank you, sir, for the talk. I'm just carrying this question forward. Now we do in the Indian scenario, we do come across patients who are transplant ineligible, and like money is also a big constraint. So I have a similar patient who is on hemodialysis. So palliative point of view, she has progressed on BTD and VCD also, there was further progression. And LEN also she couldn't tolerate. So do I have any option, or like it's the end point for her right now? Because we do come across in our practice for such patients.
Thank you for the question. So you told me somebody who is transplant ineligible, who is
60.
LEN intolerant, CKD
Yes,
dialysis dependent, has progressed on VTD and VCD. That's what you said. So again, it's all finances. It's economics based medicine. So I would say that. So if in finite finances, DARA is the way to go. A single agent DARA works. You can use DARA dose adjusted form. You can use DARA dose adjusted LEN. Okay, or even a DVCD for that matter. So I told you, if the finances are unlimited, right? Now that they would definitely not be a candidate for CAR T. Bispecifics would be another option for them. But these are just stretching it beyond, like giving some PFS benefits. So if it is just palliation, what you have thought about, and if affordability is a constraint, which is the constraint for most of the patients, I would say dose-adjusted pomalidomide, and maybe melphalan. These are the agents which I think I would utilize in such a scenario.
Okay, sure. Yeah. And another question, how strictly should we go after the FSC ratio? Because like the other myeloma parameters, they are normal, but it's only the patient is technically in CR, but we still have a FSC ratio which is high. So like we take up the patient for transplant, how much should our treatment be guided by the elevation in the ratio?
No, now there is enough data to say that somebody who is PR and even VGPR do well post transplant. So you can take up the patient for transplant, but it's what you do post transplant which will matter. So some of them who are not achieved VGPR, you must try to consolidate them before you put them on maintenance. In somebody who has had a response which is less than VGPR. Other than that, a transplant is not precluded. They are fit for a transplant if the ratio is still altered. But somebody who is less than a VGPR, try to consolidate them with maybe 2 months of induction regimen which you have given post-transplant. And then again look at the dynamics and put them on a maintenance. In such a scenario.
Similar patient who is transplant ineligible, so for them maybe I've gone to maybe 10 to 12 cycles of VCD, VRD now, and still there is some derangement in the FSC ratio is still not normal. So do I put them on maintenance or I continue with triple drug? Or if money is not an issue, try a few cycles of DARA for them?
No. So there is no data to say that you would still, most of them are like you said, not stringent CR. They are CR, VGPR patients. That is what most of the patients are rather, right? So after 10 to 12 cycles of induction, which you have given to somebody who is transplant ineligible, you would go for a maintenance. But keep a close watch, maybe 3 to 6 monthly, you follow up the patient and then take a call from them. You would not preclude to start maintenance in such a patient. You would start.
Thank you, sir.
Thank you, Dr. Aishwarya. There is one question from the audience. Dr. Krishnanathan Kannan wants to know if finance is not a problem, which group of patient you will definitely advocate quadruplet therapy, both in transplant eligible as well as transplant ineligible patients?
So this is about infinite finances. So I am of the philosophy that there is no point throwing a quadruplet at high risk patient because now there is data to say it doesn't actually work. I would say, because that's not the way to go forward. Like you say, no, if you have to invest money in a place, you invest money where you will get more meaningful PFS. So I am of the opinion that if you can treat your standard risk better, that's the way to go about. So treat standard risk better, do an early transplant, give them maintenance. You can take them off maintenance, maybe based on MRD later on, if you do inductions well. And most of our patients are standard risk. If you have a high risk myeloma, you put whatever, like the master trial just showed that, right? You can do DARA KRD, do consolidate with DARA KRD again, give it for 2 years. The high risk, the ultra high risk don't do well. So what I've seen, and I think that's what the West is also agreeing, that the high risks and the ultra high risks are not doing too well even with a quadruplet. So if in somebody who has finances, somebody who wants to go risk adapted and an MRD guided kind of do a therapy in that, on a trial basis is what you should be taking up the patient for. It will not be considered a standard of care. But for that patient, that's what. For every patient, therapy is individualized. So I would do quadruplet in that kind of a patient. High risk patient, you prognosticate, you say DARA KRD will work, will not work, but if he's ready for that, yes. But don't promise him the heaven with DARA KRD. The high risk don't do well with any therapy. The PFSs are fairly short, even post-transplant. So we just don't know how to do manage the high risk or functionally high risk pretty well.
So from the same note, if you consider this 1Q gain, we have got 2 in that. One thing is 3 copies and another is 4 copies. 4 copies is amplification.
Yes.
And 1Q will be the 1Q gain, if what we call it as. So if the patient has got 1Q gain with 3 copies, would you like to go quadruplet therapy in that patient?
So I think there is a data on that as well, because there is some subset analysis which did say that 1Q, I think 1Q, you said 3 copies, they do well with the DARA KRD, the amplifications do not. But I would say these subsets are too small to make, I would say, recommendations on a larger platform. So I would say the data is very limited to make meaningful. But there is subset analysis, I know, where it says 3 copies of 1Q does better than an amplification on a quadruplet.
Thank you. Any other discussion? Want to ask any other question? So, well, sir, there are no more raising signs and no more questions from the audience. Well, thank you so much for that fantastic and lovely lecture. You really brought light on how we should manage myeloma in our Indian scenario where the finances is a big issue. And thank you for a lovely discussion also and a wonderful lecture. Thank you so much. And I thank all our audience as well as discussants to participate in this webinar, and meet you next week, Saturday, Sunday, with another beautiful webinars. And I now hand over to Mr. Suraj Tiwari to give the final vote of thanks. Mr. Suraj Tiwari, are you there?
Yes. So thank you all the doctors for joining us today, and I am very honored for this opportunity. Thanking MSG Group, Dr. M. B. Agarwal sir, Dr. Purana sir for wonderful moderation, and our speaker, Dr. V. A. Arun sir, and all the discussant for joining us today. Thank you so much for the enlightenment. Thank you so much.
Thank you. Goodbye. Good day to all of you.
Thank you, Dr. Amit. Thank you.